Welcome everyone, this is lecture 26 of this series on fluids and electrolytes. These lectures are based on my book, Manual of Fluid, Electrolyte, and Acid-Base Disorders, a Pathophysiologic Approach to Common Clinical Problems. I am Dr. Mohammad Tinawi. I am a nephrologist in Northwest Indiana. You can find the book on Amazon. I'll provide more information in the description below. We are on Chapter 3, Hyperkalemia. Today we'll discuss symptoms, complications, and diagnosis. Let's start with symptoms and complications of hyperkalemia. Hyperkalemia has multiple manifestations, but the most important thing are cardiac conduction abnormalities. Like when we talked about hypokalemia, muscle weakness is important, but this is non-specific. You can see muscle weakness in hypokalemia and in hyperkalemia. Rarely, muscle weakness can progress to flaccid paralysis. You can also see fasciculations, paresthesia. Other nonspecific symptoms include palpitations, nausea, and vomiting. And we said you can see sometimes metabolic acidosis because hyperkalemia decreases renal ammonia production, something you need to combat metabolic acidosis. EKG is very important in hyperkalemia. It does not correlate with the severity of hyperkalemia, but EKG changes mean that we have to act fast. In one study, EKG changes had both poor sensitivity and specificity. Now, these changes are due to depolarizing effect on the myocardium. The earliest sign is peak T waves. Everyone knows about that. Then you get absent or small P waves, then PR, interval prolongation. It gets more serious after that. You get QRS complex widening, and then high-grade AV block and sinus bradycardia. Finally, you get the sine waves. Once you get that, this is very ominous. This is followed by cardiac arrest, either due to ventricular tachycardia, ventricular fibrillation, asystole, PEA. Now let's look at some EKGs. In this EKG, you can very clearly see the peak T waves and the widened QRS complexes. You can hardly make out any P waves. This is an example of severe hyperkalemia 9.3. Now, in this EKG, you see the ominous sine waves, and the QRS complexes now are very, very wide. This is usually followed by a serious arrhythmia like ventricular fibrillation or ventricular tachycardia. This is an example in someone with a potassium of 9.9. What about mortality? Now, if you have hypokalemia, it's bad. If you have hyperkalemia, it's bad as well. So the association is U-shaped. Now, this is a famous study, over 900,000 patients. When you have potassium below 4, mortality increases. When you have it above 5, also mortality increases. And for every 0.1 mil equivalent change, either way up or down, you're going to have increased mortality. Now, it is worse with chronic kidney disease, diabetes mellitus, or heart failure. This is the study I'm talking about. You can see a U-shaped curve. The best spot is between 4 and 5 potassium. Below 4, mortality starts to increase, and the lower, the worse. Also above 5, mortality starts to increase, and the higher, the worse. You can see after 6, it really starts to go up. And it is worse in patients with diabetes mellitus, heart failure, CKD. If you have all 3, it's even riskier. So it's best to keep potassium between 4 and 5. You don't want it too low or too high. How do we make the diagnosis? Well, that's easy. On any chemistry profile, we get potassium. Now we have to recognize pseudohyperkalemia. We suspect that if you have really hyperkalemia but no risk factors and no symptoms. So since potassium is inside the cells, its concentration intracellularly is more than 30 times extracellularly. Anything you can do to release potassium from the cells is going to give you pseudohyperkalemia, like fist clenching, like applying a tourniquet for too long. Now, again, have a high index of suspicion. If you don't have diabetes, you don't have CKD, you don't have diabetes, you don't have hyperkalemic RTA, maybe the potassium is falsely increased. Sometimes the sample is hemolyzed, and all you have to do is to repeat the potassium. Another example, let's say that someone's potassium is 4 and 1 week later you're doing a lab for whatever reason and it's 7. Well, the patient is not diabetic, not on any medication that would raise potassium, no history of CKD. Well, that could be false, so you just repeat it. Now, hyperkalemia can be mild, potassium 5.5 to 5.9. So here we are defining hyperkalemia as potassium 5.5 and higher. So 5.5 to 5.9 mole equivalent per liter or millimole per liter is the same for potassium, is mild. 6 to 6.9 is moderate, and above 7 is severe. Now, you don't need to get to severe to get serious complications. Patients can still have arrhythmias and die with potassium 6 and higher. Many patients are asymptomatic, especially if it's mild. Like we said, symptoms are nonspecific. The most common symptom, again, is muscle weakness, but you can see that with hyponatremia. You can see it with hypernatremia. You can see it with hypokalemia. So you need a lab to make the diagnosis. Cardiac conduction abnormalities should be immediately recognized. We need to get history and physical. We need to know if the patient has CKD, diabetes, heart failure, adrenal insufficiency. We inquire about muscle weakness. We see if the patient has paralysis, ectopic beats, etc. We really need to review the medications. Is the patient on an ACE, on an ARB, on spironolactone, etc.? And does the patient take potassium supplementations? Does the patient take a salt substitute containing potassium chloride? What about laboratory tests? Now, like I said, potassium is included on any chemistry profile, so that's easy. We get a basic chemistry profile because we need to know what the kidney function is, the acid-base status, glucose, etc. And if we are suspecting adrenal insufficiency, we need to do the ACTH stimulation test. But you're not going to wait until the next morning and get the test at 6 a.m. If you really think that the patient has primary adrenal insufficiency or adrenal insufficiency of any kind, like I said in other lectures, give the patient 0.9 saline and give them hydrocortisone 100 milligram IV Q8 hours. That can be life-saving. Signs and symptoms of adrenal insufficiency: you have weakness, you have low blood pressure, you have low sodium and high potassium, you have metabolic acidosis. Okay, so give saline and give intravenous hydrocortisone. If you're suspecting rhabdomyolysis, just check a creatine kinase, check CK. That's easy enough. What about hyperkalemic emergencies? So hyperkalemia can be chronic or can be an emergency. So once you have EKG changes, this is a hyperkalemic emergency. So if you have a potassium 6 and above, probably you should do an EKG. If you have signs like peak T waves, widened QRS complexes, admit the patient to the intensive care unit or at least a monitored unit and start emergency treatment like we will talk about in the next lecture. Rapid rise in potassium like rhabdomyolysis, diabetic ketoacidosis, tumor lysis syndrome also should prompt immediate treatment of hyperkalemia. So, based on the above, what is the definition of a hyperkalemic emergency? It is hyperkalemia associated with any EKG changes, peak T wave, widened QRS complexes, sine waves, etc. Any rapid rise of potassium, like due to rhabdomyolysis, hyperkalemia with muscle weakness or paralysis. If you have any of these things, then you have a hyperkalemic emergency. So what does that mean? Act promptly. What about hyperkalemic renal tubular acidosis? How do we make the diagnosis? We talked about that in detail in the previous lecture. I'll provide a link. Now, we used to rely on something called the transtubular potassium gradient, TTKG, to make the diagnosis. It's no longer recommended. This is based on an article by the people who invented the TTKG. I have to make an admission, most of us who grew up doing the TTKG, we still secretly do it. Okay, don't tell anyone. But I cannot, like in a lecture like this, recommend it. So what do? Well, we review the medications, and like we said, hyperkalemic renal tubular acidosis can be due to a voltage problem or can be due to type 4 RTA. Now, when you have hyperkalemia, you have reduced urinary ammonium excretion, and this is going to cause what? It's going to cause acidosis. Hyperkalemic RTA is a non-anion gap acidosis. An important cause is HIV. Now, sometimes to make the diagnosis, you need to measure plasma renin activity, plasma aldosterone, and serum cortisol. And if you're suspecting a diagnosis like that, probably you need a nephrology consultation. Now, a clue to renal tubular acidosis with hyperkalemia is normal renal function. So if you have chronic hyperkalemia, but the kidney function is normal and you don't have pseudohyperkalemia, then maybe the patient has hyperkalemic renal tubular acidosis. So you have to check that out. Hyperkalemic renal tubular acidosis is a form of non-anion gap metabolic acidosis. Like we said, it can be either voltage-dependent RTA, like you see with lupus nephritis, amyloidosis, obstructive nephropathy, or it can be due to type 4 RTA, like you see with hyporeninemic hypoaldosterone syndrome in diabetics. Now, when you have type 4 RTA, you have hypoaldosteronism by definition. You can make the differentiation based on the etiology and the medications like we just talked about. Now, patients with voltage-dependent RTA often cannot acidify their urine. They cannot drop their urine pH below 5.5 even though they have acidosis. But patients with type 4 RTA can. Now, further differentiation requires sophisticated testing. I provided here a reference if you're super interested, but usually we don't do that because it has no real impact on management. I'm going to stop here, and next lecture we're going to talk about the management of hyperkalemia.